Diet. There are so many diets out there to choose from. For example, the Mediterranean diet, the paleo diet, the keto diet, the plant-based diet, the omnivore diet, the carnivore diet. How do you choose which diet is best for you? Well, to help you answer that question, join me on this week's episode of the IQ Podcast, when I'm going to be speaking with my special guest and friend, Ashley Koff. Ashley is a registered dietitian and founder of the Better Nutrition Program, and she's going to be helping us decide how to find a personalized nutrition plan. So be sure to tune in. Welcome, everyone. Welcome to another episode of the IQ Podcast, where you can gain insights into eye health and brain health and raise your IQ. I'm your host, Dr. Rani Banik, and today I'm so excited to bring on a special guest who happens to be not only an expert in her field, but also a close friend of mine. So I am so excited to welcome today to the IQ Podcast, Ashley Koff. So Ashley is an award-winning personalized nutrition expert with over 25 years of experience helping people, businesses, and organizations get and stay healthy, powered by better nutrition. Today, as founder of the Better Nutrition Program, Ashley helms a team of clinicians, coaches, and digital health experts, delivering personalized nutrition at scale to help people enjoy optimal health span. Ashley is also the nutrition director for the University of California at Irvine, Susan Samueli Institute's Integrative and Functional Medicine Fellowship, and chief nutrition officer at VitaBoom. She's also the author of 2 books and a new one coming in September 2026, so mark your calendars. And she's also a regularly featured national media expert, keynote speaker, mentor, and advisor. Ashley lives in Maine, and she enjoys getting out in nature with her dog, playing anthems on her trumpet, and she also travels to spread the word about better nutrition. Thank you so much, Ashley, for joining us today on the IQ Podcast.
Oh, I'm thrilled to be here. I'm even more excited that you're doing this. I can't wait to listen to the different experts that you've shared with me that are coming on or have been on. You're just such a leader in your field, and this is going to be really fun. So thank you for having me.
Well, thank you, Ashley. And also, I just wanted to say that, we've known each other for at least, I think, 4 or 5 years now, and you've interviewed me on numerous occasions. And I am so excited to finally have the chance to interview you and to pay it forward. So thank you so much.
Yeah.
So Ashley, you have a really interesting background. I know that you didn't start off in health and nutrition. So give us a little history about where you came from and how you got interested in nutrition.
Sure. I was definitely uninterested in nutrition. And as the daughter of a surgeon, I was also uninterested in healthcare. It was definitely not on my to-do list. I was really interested in history, which when I went to Duke also meant that I could be in class with the basketball players. So that, proved out. And I love to sell things. So from very early on, I was interested in sort of advertising, sales. In fact, my idol was Angela Bauer. And so I worked pretty hard for my early professional career to become like her. I was trying to be tall, thin, and blonde with straight blonde hair. So that didn't end up happening for me. And also she worked in advertising, which I thought was so cool. And my grandfather had worked in advertising. So I ended up with my first job out of college being at J. Walter Thompson, and my client was Kellogg's. So I actually helped create Smart Start and Raisin Bran Crunch and a variety of different ad campaigns to sell things like Smart Start and those other, Sugar Smacks and those other sugar-based cereals, and to tell you that those cereals were good for you, that they were a great source of energy. So I was probably as far away from better nutrition as I could be in those early years, for sure.
Mm-hmm. So then how did you end up making the switch? Is it something that, from deep inside that you realized, oh my goodness, maybe this isn't the best thing to promote and advertise these types of foods?
Yeah, I'm sure there were some wake up moments. I remember listening to someone I was working on a hair color, and, she's crying, and we're interviewing her, and she's talking about multiple failed relationships. And if she just changed her hair color, maybe somebody would stay with her, just things like that. And I was like, okay, this is not, I don't want to be here. But it's interesting that you say deep inside of you. So kind of on a parallel path for all of the personal, and then professional success that I was having. I was always a great student and then doing really well in my career. my insides were literally falling apart. But I had only ever thought of myself as when I was younger, a cute, chubby kid, and then as a fat girl. Like it was just, I always had a belly. I tried all of these different dieting things. In college, I met people who introduced me to disordered and frank eating disorder behaviors, and I tried different things. I wasn't any good at them, so I actually didn't like get there, So that was like at the time I felt like, oh, I'm not just bad at dieting, I'm bad at like all these extreme things. So it wasn't actually until I had kind of given up on everything. My rock bottom was doing a 7-day goat's milk only cleanse because my yoga friend had pricked my finger, looked at my blood, and told me I had a worm. And oh, by the way, I had paid her to do that. Just things like that were completely off the rocker. And ironically, or I like to say, that we always are, that if you're out there looking for what you're meant to do, it's going to hit you in the face. So it literally hit me in the face in a bar, doing the goat's milk cleanse, kind of feeling I was at my rock bottom. And I met what today we would probably call an integrative gastroenterologist, who said, has anybody asked you, like, were you on antibiotics as a kid? And I was like, what are you even talking? Like, we're in a bar. Like, this is the worst conversation. So I actually went and saw him as a patient.
As a patient. Uh-huh.
And it completely lit me up. He said to me, first of all, it's not what you're eating or not eating, because I had been all over the gamut in terms of that. He's like, but your digestive system doesn't have what it needs to run better. And here's how we can do some of that repair work. And he started me on that path that exposed me to what today we'll call an integrative or a functional, I like to call a root cause perspective. And at the time was called complementary or alternative, or by my whole family in the medical community, like, you're complete woo. Like, what are you doing? I remember famously somebody saying to
I've
me,
heard
like,
things like that too. Uh-huh.
totally. Yeah. I remember somebody that I'm related to saying to me, you're taking magnesium. Like, what if your body becomes dependent on it? And I was like, well, actually, my body is dependent on it. It's embarrassing to me that you have a medical degree. Like, I mean, this is just these kinds of, conversations. But that really just lit me up, like, from the moment that I started to feel better. And it really wasn't even about the weight. It was literally about the fact that I could eat food and just didn't bloat out. And, I could avoid uncomfortable situations. I had traveled a lot at that time, so flying was really difficult. And it actually also helped me address at the time, which was some real severe anxiety and panic attacks. So doing that, I became this like card carrying like flag. I was like, I got to change the world. And it just, I haven't looked back from there. So that's the path that it sort of lit me up. And I've had different variations of my career at this point, but that was when I became a dietitian. Yeah.
Mm-hmm. Wow. So thank you for sharing that. I know that sometimes those personal stories can be a little bit difficult, just recalling some of those times, but they can also help others who may be going through similar situations, and just to hear someone realize, what their root cause may be and how they made significant changes in their life and made things so much better, turn things around. So we're going to take a deep dive into personal nutrition. But before we do that, can you explain to us just some technical terms, like what's the difference between a registered dietitian, which you are, and a nutritionist, or is there a difference?
Yeah. I think with healthcare is pretty confusing these days. And what I would say is the reason I became a registered dietitian is that a registered dietitian has a medical license. And so we participate in the medical field. I think I was a little naive also believing that my services would be reimbursed by insurance. And certainly as I went down what I'll call a less traditional dietitian path, taking a more root cause approach would be what the field of dietetics looked like. And that isn't the case. There are definitely many of us that are more interested in this type of approach, and there are many that are not, and so we have very strong disagreements within our profession, probably like yours and probably like so many. So, what I actually, to make things easier for people, maybe it's easy, maybe it's not. I created an analogy years ago, and I said, being a dietitian is like having an organic certification. And then being a nutritionist is like saying that your product is natural. So the reality is they're amazing nutritionists. There are some who have taught, certainly that I've learned from and who have taught and I think are incredible. But you really have to get to know them and explore their background. Because I saw somebody, who pricked my finger and looked at my blood and told me I had a worm, and she just called herself a nutritionist. And she doesn't have any, in that space, days, there isn't typically licensing. It's a little bit, it's
Mhm.
changed a little bit because now there's licensed nutritionists. So they might get a license, but they haven't gone through the work to enter the medical profession, if you will. So I had to do a residency at a hospital, did that training, and then I maintain my license every 5 years. I'm accountable, quite frankly, like on places like social media for what I
Mhm.
say. So, I think that puts me more, like makes me more cautious than maybe what many nutritionists or influencers might feel comfortable, saying where their license isn't on the table. But there are dietitians that I don't think are practicing better nutrition, and there are nutritionists that I think are fabulous. So it's a little bit tricky. And there are things like a diet DTR, a diet tech who has different skills. There are health coaches who may be supporting you in your
Mhm.
nutrition, but they're not meant to give recommendations. As a medical professional, I can give recommendations. The line stops for me as a dietitian. I'm not supposed to be diagnosing.
Mhm.
That's outside my scope, to
Mhm.
diagnose somebody with irritable bowel syndrome or, something
Mhm.
like that. Yeah.
As a dietitian, as a registered dietitian, can you order tests though, even though you may not be able to formally diagnose? Like, for example, if you needed to monitor someone with diabetes, can you order a hemoglobin A1C for them?
Yeah, it's a great question. So today's lab worlds are really interesting, right? Because today consumers can go and buy their own labs. They
Yes.
can, there are different testing companies and things like that. So what I tend to do in terms of labs, number one, I really want people to get as much paid for as they can. So if they can go to their doctor, I often am in the place of saying to the doctor, sharing with my patient, this is what I'd like you to order, and please have your doctor order it. And then we'll collaborate on reviewing. And so we'll go that way,
Mhm.
because if the doctor orders it, they can get reimbursed. In
Mhm.
certain states, you can do things a little bit differently. New York is famously, you can't do anything, on that part. And then I have clinical oversight by a physician who helps my patients be able to order specialty labs as well.
Mhm.
Not direct. I don't believe directly. Sometimes I'm not the best person to ask about the most up-to-date rules and regulations, but I personally don't order labs as a
Mhm.
practitioner. Yeah.
Mhm. Okay, that's good to know.
Yeah.
So let's talk about nutrition now. So, we know that well, at least my belief is that nutrition is so foundational to our health and in the prevention of chronic disease. And there are so
Mhm.
many diets out there. You hear about the Mediterranean diet, paleo, keto, omnivore, carnivore, plant-based. Like, what is one kind of overarching principle you would advise for people when it comes to choosing a diet that may be best for them? Like, how do people decide? Because there's just so much out there. Some of it's based in scientific studies, some of it's anecdotal. It's really just very hard for people to kind of include some of this information into their daily choices. What would
Yeah.
you advise them?
This is my favorite. You've known me for some time. I'm not quiet or shy. Tend to not be, and so I've gone pretty forcefully into rooms of decision makers and people where we're talking about what guidelines we have. I've said things famously about like the recommended daily allowance, the RDAs, that they're really dumb amounts. There's just a lot of information that is not helpful, and the primary reason is that I think people have been very well intentioned. The idea has been, for the most part, the idea at a government level has been, let's try to figure out how we help the masses stay healthy. But there's an inherent problem in that. Number one, how they define healthy is not how you and I would define healthy. We're talking about optimal health or better health, health span, living well until you just aren't living, like just drop off, and not having a long chronic disease or debilitation over time. So that's different on that piece. And then the other piece is when we look at mass or even we look at research studies, they often just don't apply to you, to who you are, the person. So when I look at that, unless I'm a 65-year-old living in Sardinia right now, the idea of following the Sardinian diet, it misses the fact that maybe it's what the weather is like, or it misses the
Mhm.
fact that maybe it's what their community is like, all of these different pieces.
And
So,
their genes also,
and their
right?
genes,
That
there's
plays a
yes,
huge
yes,
role.
there's so many. So yeah, on that
Yeah.
piece. So the first thing that I did that I think will be the most helpful to practitioners and individuals is I created a definition for better nutrition. The issue that I have is without a definition, we actually are not able to hold something accountable to whether or not it is or is not better nutrition. So the definition of better nutrition is giving your body today what it needs to run better while reducing or avoiding what can irritate, disrupt, or overwhelm its efforts. So that's a lot, but I want to break it down. Giving your body, so it's about you and it's your body today. So it's it's time stamped. It's right now, because what your body needed 10 years ago or what it needs 20 years from now is going to be different. And then to run better. So a body is an operating system. And so it's got all of these systems within. It's constantly responding to stimuli. It's running. It's not like even when we sleep, it's still running. So we need to make sure that it has what it needs. It needs to have access to the resources it needs to run better. And then what we want to look at is it's a reducing or avoiding. In some instances, we may want to reduce something. In other instances, based on genes, based on disease, based on, the harm of an ingredient, we need to absolutely avoid it. What can irritate? So something might be more irritating and thus frustrating and thus creating stress and negative experience for the body, or overwhelm. It just might be too much at one time. And then disrupting those efforts. So we know that there are things that are known as disruptors. And there are things that, oftentimes I'll describe to somebody, if you're thinking about frying an egg on the stove and you're given a round pan or you're given a paper plate, which one is actually, is the frying pan or the paper plate going to be a better tool for you? Well, a lot of times when we present things to the body, it's like, oh, is that round? Great, I can use it. And then it goes over to try to use it. And it's like, that doesn't work. Like that's going to catch on fire, that kind of thing. So the definition of better nutrition actually allows us to assess, and it brings us back to the most important piece of what's wrong with the dietary recommendations out there. If it's your body today, then it really isn't about paleo or keto. It's about Rani's keto. So Rani's keto today is going to look different than Rani's keto 20 years ago or Rani's keto into the future. Ashley's paleo could be great for her today, or Ashley's paleo might really require using certain supplements and things like that because her dietary choices are not giving her body certain things. So the foundation of dietary choice really needs to come back to being what I call truly personalized, not partially personalized, which is, a lot of what's being sold, but truly personalized. And then the other piece, and you knew I was going to go here, and the other piece is that without healthy digestion, whatever diet you're on cannot work for you. So so if you take better nutrition and you say, okay, I've been able to determine what my body needs to run better. I'm now trying out those choices. I'm experimenting. I'm seeing some results. But if I'm not seeing positive results, then I need to turn around and look at my digestion. Or conversely, before I even recommend a diet to somebody, I'm doing my digestive evaluation just to be like, hey, are we starting off at a place where your body can actually break down and use what it's getting in? So that's how I approach diets. And there is not one. Years ago, I created the term qualitarian, and I still stand by that because I like to focus on the quality. But at the end of the day, that's just one of the pillars of better nutrition. They're quantity, quality, nutrient balance, and frequency. So I can't just align with quality. I have to look at the other ones too.
Yeah, no, I love so much of what you said. And I want to add or just make two comments.
Yeah, great.
The first thing is about, eating right for your stage of life and also what's happening in your life. So for example, you were giving, examples of how things may change, but let's say women like us who are in midlife or going through perimenopause, menopause, our dietary needs are quite different than they were even before this stage in our lives. And we have to adjust to that. And we have to listen to our bodies. Do we wake up feeling refreshed? Do we not? Do we have a lot of stress in our lives? How are we eating based off of those levels? Or how can what we're eating impact our stress? Maybe perhaps put us into a more inflammatory state. So listen to your bodies. That's one thing that I always tell my patients, and it's very individualized. The second thing is you were talking about gut health, and in integrative and functional medicine, we always go by the belief that everything arises from the gut, or if there's a problem, fix the gut first. And if you can fix digestion, but also work on your microbiome. I'm sure you talk to patients about this as well. That will put you in a better state because the gut is responsible for so many metabolic processes, creation of neurotransmitters, and it interacts with our immune system and it helps to process some nutrients and vitamins. So it does go back to the gut. And even for eye health, I talk to my patients about gut health, and they're kind of like, why, Dr. Rani, are you talking to me about what, my gut's doing when it's my eyes that I'm here to see you for? And I try to explain that. So thank you for bringing those two things up. So I wanted to ask you next, Ashley. So in the past, I would say 8 to 10 years or so, there's really been a trend towards really trying to track what we're doing with our health. We have all kinds of health trackers on the market, sleep trackers, continuous glucose monitors. These are wearable devices, some of them. So what are your thoughts on some of these health trackers? What's some advice you would give people?
Yeah, well, one of the reasons I think that they've become so popular is not just the rise in technology. I was very early on with digital health, and I remember sitting in a room where it was the Consumer Electronics Show. It was the first year that there was a digital health conference, and there were a couple of us on stage, and I don't think that the way that I conveyed my message was as exciting as the way that some of the others. A lot of patting on the back about like what was being discovered, and I said, at that point, hey, talk to me when you have gone beyond just collecting data and actually have evidence of behavior change. I think we're in a better place today with behavior change resulting from what we can see from wearables, but we do run the risk of just being in this space where we're collecting a lot of data, and also where we're actually overwhelming our systems with data. So our beings, our bodies today, and definitely this applies so much to your field, our eyes and our brains, I refer to it as infobesity, where we just have too much information coming in, too much stimulus, too much. And even if it's great information, it's too much. And so data can feed into that and really overwhelm. So I think there's a potential downside to just how much we're able to track and collect. On the flip side, it does hold true today, as it has for decades, that the best, I think on a consistent level from a research standpoint, what has shown to help people create behavior change and maintain behavior change that results in weight loss and health and things like that is actually journaling. So there is some value in tracking, right? Because part of it is, for years, I would have people come into my office and I would ask them about even what they had yesterday. And it's like, if they can't remember, then I can't help you on that part, right? So one of the things that tracking does is it helps us to actually see what our choices are. The other thing is we're being invited to invest our time, our money, our effort in collecting information to kind of be our own research study today to see, how something works. So I absolutely love today that the concept of ROI, like actually what is the return on that investment, whether it's about a supplement, whether it's about food choices, whether it's about fitness, so one of the things that I do with all of my patients is I'll say, we want to make sure for any recommendation, any experiment that you're conducting to see if it's better for you, we always want to look and make sure that we have a plan to assess it, right? To see if what is happening. And so if somebody's just selling you a supplement and saying, oh, I know this your body needs, hogwash. But if you're actually taking a supplement and you're saying like, okay, my vitamin D was 30, and then I took, X amount for however many days, and now it's 32, we note by the speed at which it increased, whether it increased, we can understand if we're on the right path. Additionally, there are things that we can actually do better today. So you mentioned a continuous glucose monitor. We, in the past, have been able to prick our finger and see our blood sugar in a moment. That's not going to help us get trends at all. We also have something called a hemoglobin A1C, but the issue is it's a 90-day average. And with averages, things can average out to look pretty good. So I've had people who are technically think, with a 5.3 or 5.4 that they have really good blood sugar. But when we wear a continuous glucose monitor, we see that while they're sleeping, their blood sugar is always crashing, or it's going high, or we see that in the middle of the afternoon, X is happening, or they're training for a fitness thing and we're not seeing recovery the way that we'd like it. So with a continuous glucose monitor, I actually learned so much with you about how your body is responding to at least there are 40 plus factors that impact your blood sugar, not just carbs. So there are a lot of things, that we want to look at on that part. So if I had to sum it all up in that space, I would say that when it comes to the era that we're in with wearables and with tracking, the pros of it are that we can do a better job of understanding, and we should do a better job of setting up a scenario to experiment and to evaluate the data from ourselves doing that experiment. So if I reduce my sugar intake, what does that look like? Or if I go to bed at a different time, what does that look like? The considerations, I wouldn't necessarily call them cons, but the considerations is the amount of data, collecting fatigue. And then I think one of the most important ones is cost. I don't want anyone to feel that if they don't have access to these wearables, that they can't actually evaluate their health, because there's so much. We have on our website, we have a ton of free evaluations that are just, easy for you to do. I think they're easy, but they're fun experiments, to kind of gamify things, to test it out. And often they give me as much, if not more information than a lab value is going to give me, or, other data might give me, so we want to make sure that we are presenting better nutrition and certainly better health outcomes as accessible for everyone. For sure.
No, that's so important. And I think we'll definitely put the links you mentioned in the show notes if anyone's interested in. Ashley has a huge library of these self-assessments. So certainly take a look and maybe do a few of them and share them with your friends and family, because they really can really make a huge difference, just to make you aware of some things that you can focus on. And I love what you said about the journaling, because it's such an inexpensive way to do it, to track it yourself. You could even download, I'm sure that there are plenty of free apps that you can download available online to track your meals, to track your activity, to track your sleep, your mood. So definitely consider doing some of those things on your own, and you don't have to.
And I do, you'll laugh, but I do pen and paper. And part of that is I don't want to be on my devices anymore. So that's also, it's just for consideration, in that way, whatever works better for you.
Yeah, always. I love writing as well.
Yeah.
All right. We are back with the IQ podcast. We're chatting with Ashley Koff, a registered dietitian. So Ashley, I wanted to talk to you about another trendy health topic, which is the use of medications known as GLP1 receptor agonists. And I know that you are doing work, and your next book is going to be on this topic about GLP1 and perhaps natural ways to boost GLP1. So tell us a little bit more about that from a registered dietitian's perspective.
Yeah, this is interesting to me. It isn't something I was taught about in school. I don't know for you, incretin hormones or the peptide hormones known as CCK, PYY, GLP1, GIP, whole alphabet soup going on that part. So I'm kind of grateful to, semaglutide and tirzepatide, to these, medications, Ozempic, Wegovy, et cetera, for creating the landscape in which we can have a bigger conversation. But we do need to have that conversation. So, one of the things, and it's funny because I'll take us right back to where we were. So this is a perfect full circle moment. My first exposure to GLP-1 as a hormone, which I then later learned is really a set of hormones, CCK, PYY. There's another one called oxymodulin, but it doesn't get much attention. And GLP-1, I call them your switch hormones. So they're really your metabolic switch. In many of us, our switch is dysfunctional or delayed, or it's operational, but our choices are suppressing its capabilities. And so these hormones, they're only meant to act very quickly in our body. So the way that our body's designed is that these hormones, we have receptor sites in our brain and our pancreas, we're seeing in maybe even in the thyroid, like a lot of different places. These hormones the stimuli that they're responding to is the presence of food. And in particular, it tends to be proteins and fats, a little bit more than carbohydrate. And when they experience that, they pop on really quick and they switch on a whole cascade of events. So they switch on leptin, which is another hormone that says, hey, brain, you've actually gotten food in. So I want you to stop that hunger response. I want you to start to feel full. You should start to enjoy that feeling full. And then the second one is insulin, and it turns around and says, hey, insulin, you need to go to work. You've got work to do. You got to go into the blood and pick up the sugar, and it's time for you to take that into the cells. So what's interesting is that for many of us at different times in our life, remember that time sensitivity of better nutrition, as I said, we fall into two categories: dysfunctional, delayed, or suppressed. And if these hormones are not working, and again, they're just meant to pop on for about 2 minutes and then enzymes come in and erode them, all they do. They literally are like a pilot light. They just switch
Mhm.
things on. But for many of us, that switch isn't working. So the question mark is, why isn't it working? Genetics could be at play. Maybe you're not forming, or the deployment of those is not happening as effectively. Or it could be, guess where they're made? Well, they're made at the lining of your digestive tract. So if your digestive tract has experienced insult or injury throughout the digestive tract, but especially in the small intestine and the colon where these are produced, then they're not going to be produced and deployed successfully on that part. And so you have these receptor sites that have been unsatisfied.
Mhm.
And so what will happen with that is that they're not getting that. When they don't get the messaging, you're not actually getting the messaging. This was my whole childhood. I did not feel full. And what's interesting is with perimenopause, sadly, this has been a resurgence for me. So I've had to come back to and shift my eating and shift my choices and look at, are things delayed or dysfunctional again? And how do I do that repair work? So what the medications are doing is the medications are what we call an exogenous, an outside of the body form of this hormone. And so they come in and they stay on, first of all, they're like, if your regular amount that your body produces is 1 shot of espresso, they're like 4 shots of espresso. Like it's like bring in the big guns, right?
Yeah.
Yeah.
Okay.
And
Yeah.
they're staying on right now for about 24/7. So they don't turn off. So remember, I told you that the ones in your body normally stay on for like 2 minutes. These are staying on 24/7 for like 7 days or 5 days, 6 days, depending on how long it's lasting. So there's a really big difference. On the one side, it's flooding your system and all of your receptor sites, maybe even for the first time in your life, are getting these messages that are like, I know how to feel full, and boom, insulin, go, and all of these other pieces. But they also are staying on while you're sleeping. So I've seen people where we have low blood sugar overnight, and it's reducing. We've seen HRV, heart rate variability, being suppressed, and some of these other issues. So when we use something externally, and this might be the same. Let me give an analogy. We take thyroid medication, we take thyroid hormone, we take insulin actually as a hormone. So this is not a negative situation. These are hormones that can be dosed in different amounts. So that one of the differences between, say, taking a semaglutide or tirzepatide versus taking a branded amount that you can't adjust is that when you take the actual ingredient, like I might adjust it for my patient. I might say, hey, going from 10 to 40, I want you to go from 10 to 15, and I might want to keep you at 15, that kind of thing. But when we look at that, what we're recognizing is that if you take thyroid hormone or you're taking insulin, we're also supposed to be working on choices. This is an opportunity now that when our body has what it needs to operate. So now, what is my better nutrition? What are those choices? What are my better lifestyle choices? So if somebody is using the medication and seeing benefit, if they're on a semaglutide or a tirzepatide and seeing benefit, that's like the answer. Like you're like, okay, I know your internal is dysfunctional, delayed, or suppressed. So can we, while you're on that medication, just like if you're on an antidepressant, can we use therapy, or can we use nutrition, or can we use sleep to help you now deal with the actual root cause of your depression? And so I am, as a practitioner, is actually in this super excited space, because the work that I've been doing over the course of the last 20 years has been to help people optimize their endogenous production and deployment of those hormones. So we can do them together, but because things like Ozempic and Zepbound, et cetera, because they're so exciting and popular and creating such dramatic results. Remember, that's 24/7. We're at this high dose. We're hearing a lot of, in my opinion, mistaken messaging. So one side of that mistake would be that it's either an issue or that one would have to stay on this for life. It's a maybe. You're a person. So maybe while you're on the medication, we're able to do the work. We should do the work to optimize your natural. And when you get to your maintenance level, maybe over time we could take you off of this and have you stay off it successfully, or maybe we could take you off of it for a period of time. But if life happens, say like perimenopause happens, and suddenly you need it as a tool, this just shouldn't be viewed with any judgment. This is a tool that we have and we're able to use. Similarly, in the supplement space, if anyone, with the exception of one, I'll mention that, but is selling themselves as nature's Ozempic, that is 100% misinformation. So there are many ingredients. We could look at berberine, we could look at probiotics, we could look at, postbiotics, we could look, I mean, there's so many different things that could help the body, either helps the insulin response or helps the body naturally support the production of these hormones. And if you only need a little bit of natural optimization, that may be all that you need on that part. But most of those are improving it maybe like, 5% to 55% to 65%. In order for you to actually see and experience an appreciable suppression in your hunger response and the ability to feel full, or to see that insulin, start to peak, and to see CCK, PYY, and GLP1 be improved, the threshold is really about 400%, so above the normal action. So the only one that I've seen research on that does this per their research at 600% is an extract of hops called, I can never pronounce it, it's from New Zealand, but it's called Amarasate. And I think the brand
said extract of
hops, like
hops.
Yeah, exactly. Not beer. And it's an extract that also has, it's been very refined to make sure that anything else that we wouldn't be taking in, wouldn't be challenging to the body. And that one,
pure, basically, it's like a pure.
Yeah, exactly. And so I talk about it a lot, like instead of a statin, it's like red yeast rice for those of us that understand, that comparison. But you have to take it twice a day. So, and it lasts for about 4 hours. So that's where you're seeing a much more prolonged impact, and it can be extremely useful. So sometimes I'm using that in combination with a semaglutide medication. Sometimes I'm using it instead of a semaglutide medication. Sometimes I'm using it when somebody, is coming off. So there are a variety of different ways, in this. But I think to me, the most important piece for us to understand is that if our end goal is optimal health span, I call it better health span. So we want to live longer, we want to live healthfully, and then just drop off. Better nutrition is foundational to that. And you can't have better nutrition without better digestion. And so what we've learned is that this metabolic switch, this switch set of hormones, needs to be able to be activated at an optimal level in order for our metabolism and our metabolic health to feed into and give the body, the ability to use what it's getting in and make those better choices. I love talking about this. We are literally at the starting point of, not the starting point of the medications because they've been around, not the starting point of understanding GLP-1 because we've understood it as soon as the first bariatric patient or maybe not the first, but after we saw bariatric patients. But we're at the beginning of trying out these different treatment plans. And so if you're somebody who is on the medication or you are seeing a patient who is on the medication, there's really two things to consider. One of them is, are they doing the work under the hood? So the medication should be enabling you to do the work under the hood to optimize and make sure that we're repairing gut health and, doing all those other pieces. And then the second part of it is to look at side effects in a different way than they're being communicated. So the mechanism of action, when you feel full, it's because your belly has sensors and your small intestine has sensors that trigger this response to occur. So if somebody, when these medications are working, they're actually delaying what we call gastric emptying. So they're slowing your motility. Well, many of us come already, I did as a package, I already had slow motility. So if you put this into my system and it was already a slow system, I have the potential to really shut down my motility. That is not a positive on any front. From an overall body system, we're also slowly identifying that different organs may have receptor sites. And we're also learning about the interaction of the vagus nerve, which I'm sure you're going to talk about in many podcasts and talk on this part. So we really have to make sure that we look at and we listen to somebody. I would imagine if somebody is on this medication, there could be changes to their eye health. I would imagine, and even positive changes because of changes in blood sugar. But we also have to look at if motility isn't happening in the gut, they might not be absorbing and getting in their lutein, mesoxanthin, and zeaxanthin, and having issues. So it's really important that we look at evaluating a patient in a total metabolic health approach when they're on these medications, and seeing what we can optimize, and recognizing that really everything can tie into the medication as I hate to even use the word side effect, but just as an outcome of what somebody's doing. And then, okay, so what do we need to adjust? It doesn't mean, oh, you go off the medication. It's what do we need to adjust? Or maybe you aren't a candidate for the medication right now. So it's a lot to consider, but I love it. Yeah.
I have to say that you're probably one of the pioneers in this. Not many people are talking about what else should be done for patients on these drugs. Everybody just, at least the colleagues that I have who do prescribe them, they tell the patients, well, basically you're going to be on these drugs indefinitely. And if you come off the drug, you're going to gain the weight back. That's the response or the advice most patients get is just stay on the drug indefinitely. But what your message is that do other things to help supplement the action of the drug, so that perhaps you can get a little bit of your natural, your those triggers or those peptides working. And so you're not reliant on it, and you may be able to successfully get off the medication and maintain the weight loss and the other health benefits. So I really look forward to your book, because I think it's going to be really eye-opening, pun intended, these medications, because again, they have taken over the world. They're like the hottest selling drugs in so many countries, and it's a multi-billion-dollar business. But then there's the other aspect of this is, the overall health aspect, and also, what is also economically feasible, right? Because these drugs are very, very expensive. So one other thing I wanted to mention, you were mentioning their potential eye effects or benefits. So we know that a lot of these medications help people control their blood sugar. So they have done wonders for some patients with diabetic retinopathy, for example, getting their eye issue under control. On the other hand, there was a paper that was just published last month that associated the use of semaglutide with a particular type of stroke to the optic nerve. It was a huge database out of Massachusetts, and they looked at tens of thousands of patients, and they found that the patients who were on some of these medications had a higher incidence of eye stroke, which is a little bit alarming. So hopefully, though, I don't want to scare anybody with that, but just be aware that these drugs are not without potential risks.
And Rani, who would be a candidate? This is just great for me to know from a patient standpoint. Who is someone that I should say, hey, if we're either on this or before going on this, we should have your risk of eye stroke evaluated? Who's the candidate there, or is there a way for us to track that without without sending people in for unnecessary testing, and things like that?
Yeah, that's a great question. So the biggest risk for this type of eye stroke is an anatomic risk factor. So it's the way the nerve looks. It usually looks like what we call a quote unquote very crowded. So it's a lot of nerve tissue going into a very small space. So patients who have crowded nerves are at risk for this type of eye stroke. The only way you would know that you have a crowded nerve is to go get your eye exam. So I'll put in a plug for that then. So remember, if you're listening, everyone should have an annual eye exam after the age of 40. And if you're on one of these medications, let your eye doctor know, hey, I'm taking this medication. Could you please check me to see if I have a nerve that is crowded or smaller than, more compacted than normal? And that would kind of alert your eye doctor a little bit. So unfortunately, there's no external risk factor other than the main risk factor is internal.
And that's so interesting, because I don't think that my normal, like I have a pretty robust eye exam, but I don't think I normally would have said like, hey, do I have a small or do I have a crowded optic nerve? I think that when I've been concerned about macular, I think that is a different, obviously like a different side of it. So I think that's a great, it's actually one that I'm thinking like, hey, let's add to the list of questions that we offer to patients. So if they start asking that question, that might, so if you're listening and you're an individual, be proactive about this, and ask that question.
And this is, again, it's just brand new. It was just released, it was like making all the headlines like, oh, these drugs lead to eye stroke. Not in everyone. So again, I don't want to scare everyone, but just be aware and have a conversation with your eye doctor. And if you're an eye care provider listening to this, ask your patients, are you on any of these medications? Just so you can make them more aware. But this has been such an enlightening conversation, Ashley. Every time I speak with you, I learn so much, and you're just a wealth of knowledge and your experience also. What's next in your career professionally? I know you've done quite a lot with your business. You've worked with some very large companies and well-known people in the healthcare space. Like, what's next for you professionally?
Yeah, I'm trying to change healthcare to make truly personalized nutrition more accessible. So that's just a plug to anyone who wants to partner to come find me. I tend to look at that. I take probably a three-pronged approach to it. I like to make our resources available directly to consumers. So we have what I find very cost effective, if you will, price points for, you mentioned our resources,
very
reasonable, and things like
yes.
that. And we have coaches and clinicians that you can work with. And then we partner with organizations that are doing healthcare, but don't have the personalized nutrition side. And so that's been, really exciting for me. And then the third part you mentioned in my bio is I really enjoy teaching practitioners, and I will scale my impact and we will really change, and make this more accessible by being able to have more practitioners who understand their value in truly personalizing nutrition, and also how they can finding ways to make that happen more successfully. So in the short term, I got to get this book written. I'm writing the book, and then also we've got a website that is launching in collaboration with it, because things are too new to be able to have them all in the book. And I don't want to be held accountable. I want this book to have longevity to it. And so I want to make sure that what's in the website is going to help you and support practitioners who want the research. As you said, like we may have intel. The research, future eye stroke research, that illuminates what these results mean. So, and then also trying to do it in a way where I take care of my own health span. So I don't think of myself as like the N of one for everyone, but a lot of what I try to do in my life helps inform whether things are going to be doable, or I feel like, it's doable for my patients. So trying to live a more balanced life too.
Yeah, I love that all. Well, I wish you the best of luck with the new book. Do you have a title for it yet?
So the title is definitely The Switch. I think we'll be playing around. If you guys don't mind to join me on social media at, Ashley Koff Approved or at the Better Nutrition Program, we'll be playing around with some of the subtitles. I want people to understand that activating your metabolic switch leads to metabolic health wins and weight health wins, but that's a mouthful. So the subtitle that sort of explains what the switch is what's up for debate right now. So if anyone has any great insights, please share them with me, and I'll make sure that you are properly acknowledged, for that part too. So I appreciate it. Yeah.
And how can people learn more about you, join your community perhaps?
Yeah. So we're at the Better Nutrition Program. When you pop onto our site, I think you actually get a pop-up. I don't know how people feel about that, or you can drop to the bottom and see those free experiments, check out the services that we have. I'm on most of the social media. So if you want to, I provide a lot of content there. I do the Better Nutrition Program. I think it's actually Better Nutrition on TikTok, Better Nutrition Program. So if you have questions and you want answers, try me there, and I may just be able to answer your question, or at least provide a context for how you can evaluate making your choices.
Absolutely. And a few years ago, Ashley and I collaborated on a project, an eye health questionnaire. So we will put that link into the show notes. So please check that out. And if you're a provider, share it with your patients as well. It's a really useful tool.
Wonderful.
Yeah. Well,
thanks so much, Rani.
Ashley, thank you for your time and sharing your expertise. And I wish you all the best with your future endeavors. I know you'll be so successful. Thank you.
Thank you.